Hello, I'm Janet Dean. I am a pediatric nurse practitioner at the International Center for Spinal Cord Injury at Kennedy Krieger Institute. And today I'm going to talk a little bit about habilitation, obtaining ongoing therapy services. I do not have any disclosures. So my objectives today are just to discuss briefly about a difference between habilitation and rehabilitation, talk about how to determine your therapy benefit, and strategies for helping to maximize when there is a limited amount of therapy. Rehabilitation refers to the process of helping people regain skills or ability that they may have lost or have become compromised as a result of acquiring disability. Habilitation, on the other hand, refers to helping a person with a disability keep, learn, or improve their functioning for daily living. So rehabilitation and habilitation go hand in hand. And we know that most children with AFM are very young, and so they have very few life skills to fall back on. So it's very important that they're receiving therapy to help them move forward and advance with their expected developmental sequencing and ongoing growth and development. So along with rehabilitation, there's always habilitation goals, but unfortunately, there's often limited therapy benefits. So the first thing that you would want to know about is what are your therapy benefits? So this can be found by calling the customer service number on the back of your card. And one of the first things that people should do when they have a child with special needs is to ask if there's a case manager available to help them. The case managers are often nurses, and they can really be your child's advocate and help you navigate your child's need through the insurance system. Medicaid may also have case managers through their program also. Parents have told me that they work really hard to create a picture, tell a story, create a narrative about their child, and explain exactly what AFM means, because the case manager may not know that, and exactly how it affects your child. And then if you do have a case manager, keep that case manager informed as you move forward with different needs that your child has. So you want to first ask about your outpatient rehabilitation benefit, and that would be how many visits do you have per year? Are PT and OT combined visits, like in one basket, or are they in separate baskets? Because if they're combined in one basket, for the most part, you can bill, if you bill PT and OT on the same day, it's only charged as one visit. Some insurances have what they call a soft cap. So you generally have an allotment of 20 or 30 or 60 visits per year. But some insurance has a clause and additional visits if medically necessary. And then some policies may have unlimited therapy benefits, generally qualified as medically necessary. It's often difficult to obtain additional therapy visits once your visits have expired. But some things that you can try is whoever has the health insurance, you can try talking with your HR benefit representatives, and many companies are self-insured, and so they may have some flexibility for getting some additional therapy benefits. You can potentially change insurance. I know I fractured my pelvis, and I didn't know what my rehab benefit was when I did that. So you may need to change insurance down the road if at all possible. Sometimes patients have told me that they've been able to convert their inpatient rehabilitation days into outpatient visits. And if you do have a soft cap on your therapy, once you've expired or exhausted those benefits, you can have your therapist write a letter of medical necessity for extra visits. We haven't had too much good luck with this more recently, but it's always worth a try. You want to know about your inpatient benefit. Is it a one-time inpatient rehabilitation benefit per diagnosis, or do you have an annual rehabilitation benefit? Some people have 20 days, 30 days as an annual benefit. And then some insurance policies have rehabilitation days as medically necessary with no real limitations. So once you know what your benefits are, you want to begin to do some planning. And at a minimum, children need to have an annual evaluation with your medical team leader, and that could be your rehabilitation professional, it could be a neurologist, orthopedist, your primary care doctor, but meet with your team leader to get an idea of what your year is going to look like. You want to meet with at least a physical therapist, occupational therapist, and if you need a speech therapist, at least once a year to have an evaluation. During these evaluations, you want to discuss your goals for rehabilitation and then make a plan to how to distribute your limited visits over the upcoming period of time. Another thing is evaluate the fit and function of any of your orthotics or equipment that will be needed for rehabilitation, because you don't want to start a bout of therapy and have your orthotics not working because you don't want to waste some therapy benefits with that. And then the other thing you could discuss is, there are any upcoming procedures or surgeries planned in the future that you might be able to take advantage of an inpatient rehabilitation visits to be able to save some of your outpatient therapy visits. So, and your inpatient rehabilitation stay, usually most children have had one inpatient rehabilitation stay after their diagnosis of AFM. And if your child didn't have one, sometimes you can request admission for an initial rehab stay. Another way to be able to get rehabilitation inpatient stays is if you need medical management. Ventilator weaning is one example. Also, if you have a surgery and you need an immediate post-op rehabilitation, in these cases, it's often easier to get in inpatient rehabilitation stay if you have a genuine medical management issue. Other ways that we have had some luck at getting inpatient admissions, a planned inpatient admission for intensive therapy. And these are often delayed postoperative admissions. So we've admitted children that have had nerve transfers, and at the time that they're expecting to begin, the nerve transfers to begin working. When mobility restrictions have been lifted from a surgery, say if you had a scoliosis surgery and you had some restrictions before you could start to do intensive therapy. To do this planning, you want to talk to your surgeon and ask them to request an inpatient admission, and find out specifically when the mobility restrictions are going to be lifted. For the rehabilitation team, if you can meet with your rehabilitation team prior to the surgery or procedure, so you can have a good plan for when rehabilitation starts and make sure that you have good goals for intensive therapy. You can, in order to obtain this inpatient rehabilitation, the rehabilitation program will need to start usually about a month before the proposed admission and start with a prior authorization letter. And be sure that you use the specific disability that is caused by the AFM, again, because there's such a varied range of outcomes from AFM. You'd want to document any prior progress that you've made in therapies, goals for the admission, increased intensity, that there'll be increased intensity, and there'll also be a multidisciplinary team to work with the child, and you can list the number of hours of therapy that will be provided during, daily on that inpatient stay. And we have been able to admit children that have had nerve transfer only for one extremity by making a case for intensive therapy. Parents, you're going to need to help out with this too. You're going to need to obtain some supporting documents from other specialists. You might get a letter from your PCP your surgeon, your occupational therapist to support your need for intensive therapy. And then talk with your case manager. Parents will tell me that they are very persistent, and our case managers have parents really being persistent and just kind of hounding until they get an answer about whether the admission will be approved. You want to maximize your outpatient therapy benefits. As I said before, PT and OT on the same day, and aquatics can often be bundled into that as it's billed under PT and OT. You want to ask if you can increase the hours for each session. Insurance generally allows billing for multiple hours of therapy for each visit. So that's a way that you can get additional therapy time. We found that bouts of skilled outpatient therapy are the best way to maximize a limited therapy benefit. We have sort of a long-term model where you have therapy 2 to 3 times a week for 4 to 8 to 12 weeks, or a short-term bout with 1 to 2 weeks of daily intensive therapy. And sometimes the short-term bouts can work well for older teens that have more school demands and social activities. So this can be done on like spring break, summer break. At discharge from that therapy bout, you want to make sure that you have a written home rehabilitation program, orders for any new equipment, and letters of medical necessity for any new equipment to complete your home program, and a plan for a return for therapy. So when do we expect that you'll be returning for therapy or at least a reevaluation? And then, of course, as Courtney's talked about and other folks have talked about, there's the home therapy program. And I often talk to parents who find this difficult and frustrating. Their children, don't want to cooperate as well for them as they do for the therapists. It's hard to keep kids motivated. But as Courtney has said, the home therapy program is really what's essential for helping kids continue to make their recovery, not the therapy bouts that they do. So integrating home therapy into your child's routine, encouraging your child to do as much as possible. We do have an OT who often talks about pulling up your pants is activity-based therapy. Maybe try getting some help with the implementation of this program. If you're a working parent and are going to have to pay for after-school care, could you go to your local college or university or even community college and see if they have a PT, OT, or a nursing program and hire a part-time nursing student to help? Maybe implement that home program. And if you do have home care nurses, maybe they would help. That can be variable, but often when the nurses get to know your family, they're willing to help. And of course, as we talked before, it's not all work and no play for children. So we can look at adding in childhood activities that can accomplish therapy goals. Children may want to participate in swimming, singing, crafts, cooking, martial arts, or dance. Children that are more mildly disabled can join in classes with their friends if the instructors are willing to help and make modifications. There are also other types of therapy that might be more fun, such as hippotherapy or art therapy or music therapy, although these are generally an out-of-pocket expense. And then last but not least, able-bodied or disabled sports. As Dr. Oleszek and others have talked about, we want to get children back to doing the activities that they love, and sports is a great way for children to get active and continue their rehab benefits in a hopefully more fun way. So some final thoughts that I wanted to leave you with: be persistent. Parents tell me that they have to be persistent, that they don't take no for an answer. They keep trying different ways. Have high expectations for your children. Encourage them to do as much as they can for themselves, and then find inspiration both for yourselves and for your children. And I have some couple of slides about people that I think are very inspiring. Ed Roberts had polio at 14 years of age, and he went on to do amazing things. Judith Heumann had polio at 18 months of age, and she worked in both the Obama administration and the Carter administration. And then, as we saw, Sarah Todd Hammer, who is also very inspirational. Look these people up on Google and look on YouTube videos. They all have videos that can be very inspirational and helpful. Thank you for allowing me to do this presentation.